we are talking about syphilis, we should also test for other STIs and offer pregnancy testing in women. Anyone in an outbreak area who is sexually active should be offered STI testing, including syphilis serology, regularly. Recommendations vary between outbreak regions. Check with your public health unit, CDC or sexual health unit. Testing pregnant women up to 5 times during pregnancy is important in preventing cases of congenital syphilis. Write syphilis serology on the pathology form. Bloods will be screened with a treponeme syphilis test like syphilis EIA. If reactive, a non-treponeme test like an RPR or VDRL will be performed to determine disease activity or response to treatment. A second confirmatory treponeme test will also be performed. If someone has tested positive for syphilis, these tests will remain positive for life. If ulcers and sores are present, swab the lesion and ask for a syphilis PCR test. Diagnosis may be confirmed by direct identification of T. pallidum from the ulcer. Testing may be positive prior to seroconversion in very early cases. With patient consent, include HIV and hepatitis B testing when performing syphilis serology. Include a viral swab for herpes if any genital ulceration is present. In patients where prior syphilis treatment is documented, only an RPR test is required. This is to determine reinfection or treatment success. Diagnosis of syphilis is a clinical assessment using a combination of physical examination and treatment and serology history. If you have clinical suspicion of syphilis but the serology is negative, repeat the testing 2 to 4 weeks after.
Asymptomatic persons with a positive syphilis serology may be classified into early latent infectious syphilis or late latent non-infectious syphilis. This will depend on the interpretation of previous serology, the clinical and treatment history, as well as the epidemiology. The past results of serology will help determine how long the patient may have had syphilis. Treatment of the patient depends on the duration of their infection. Accessing previous serology results for patients vary according to different jurisdictions. If you are in a state or territory where there is a syphilis register, contact the relevant body that is responsible for managing it. The register may be able to provide previous history as well as treatment history for your patient. This could be the local public health unit, the CDCB, or the State Sexual Health Service. If the patient is a regular patient in your clinic and you need to ascertain what the patient's previous serology is, it is important to look up your patient management system to determine the history and previous treatment regimes. If the patient is a regular patient of another clinic, it is important to call the other clinic to determine the clinical history and treatment history from that clinic. Once you have the relevant documentation, contact your local public health unit, CDCB, or your local sexual health unit to gain assistance for the interpretation of the results. If there is no history and you are unable to obtain a history of previous syphilis diagnosis or treatment, it is important to consider the case as late latent syphilis and treat as if that syphilis has been there for more than 2 years. This involves giving 3 doses of benzothine penicillin, 1.8 grams intramuscularly weekly for 3 weeks. This will ensure cure and prevention of tertiary syphilis.
Do not wait for test results. Treat patients at the time of first presentation for all patients who have symptoms consistent with infectious syphilis and for all named contacts. Treat with 1 dose of benzothine penicillin, 1.8 grams by intramuscular injection. Patients diagnosed by serology should be treated as soon as possible, ideally within 2 days of diagnosis. Cases of syphilis of less than 2 years duration also need 1 dose of benzathine penicillin 1.8 grams by intramuscular injection. For syphilis of more than 2 years or unknown duration, the patient must be given a course of 3 doses of benzathine penicillin 1.8 grams. Each dose must be given 7 days apart. At the time of the first treatment dose, blood should be collected to provide the baseline used to assess response to treatment and to check for reinfection. RPR testing at 3, 6 and 12 months following treatment is important to determine the response to treatment.
Timely contact tracing lies at the heart of an effective health response for syphilis and needs to be prioritised. The staging of syphilis dictates the look-back period. Look-back periods for primary syphilis, for example, is 3 months, plus the duration of symptoms. The look-back period for secondary syphilis is 6 months, plus the onset of symptoms. And the look-back period for early latent syphilis is 12 months, plus the onset of symptoms. This is due to the highly transmissible nature of syphilis and its rapid spread throughout the community. If syphilis is transmitted to pregnant women, this can lead to serious complications like fetal death and congenital complications. Contacts of infectious syphilis should be prioritised and seen and treated at the earliest possible time. Late latent and tertiary syphilis are non-infectious, but patients should let their regular partners know to get tested. When a contact presents, health centre staff should aim to get them tested and treated in the earliest possible timeframe. Follow-up appointments can be useful to revisit contact tracing, just to see if there are any other contacts that weren't named in the initial consult. If the diagnosing clinician is unsuccessful at eliciting contact names, think about who else in your local area might be able to assist. Seek support from your local partner notification services located at the local STI clinic or public health unit. Common strategies for eliciting contacts might be to get the person to write down the names, or getting them to point at a name from a list, or alternatively getting them to point towards a photo. It may also help to explain other risks, like the risk of reinfection from a contact, and also the other health risks, such as from mother to a baby. Explain that you aren't going to judge them for being with someone from the wrong skin group, or if they are married, or if they're having sex with someone that's married. These 3 behaviours may elicit particular shame and become a barrier for people naming contacts. Reassure your patient and explain the methods that are used to maintain confidentiality.
For more information about syphilis, check in with your specialist sexual health unit.